as I said, the purpose of today is really to gather together and have some discussions about what we are trying to achieve with the ear health strategy and what we can continue to do and what things we need to think about really focusing on going forward. And I will open with some comments. Sorry, for those people who I haven't met, I think I know most people in this room. My name's Peter Richmond. I'm a paediatrician at the Children's Hospital and a researcher at the University of Western Australia and Telethon Kids Institute, and have really tried to focus on ensuring the best health for our children by preventing problems, particularly with infectious diseases, before they occur, or ensuring that we get the appropriate treatment and management when problems do occur. So this trying to really progress the ear health strategy is something that at a sort of latter stage of my career I'm very keen to make sure that we can make a lasting difference for Aboriginal children throughout the state particularly, but also for other children who are also at risk of having problems with ear health and hearing. So I thought it would be, it was suggested that it would be a good idea that I update everyone on the ear health strategy and certainly to reflect on the contributions that we've had over the last 12 months in thinking about how things have been going and where to next, which I think is really important. And, you know, again, thank you, Frida, for such a fantastic acknowledgement of country to welcome us all here today, and I really would like to thank you for that. Now, this was the vision and purpose that we described when we first started talking about developing an ear health strategy for Western Australia, really on the basis that we had a significant number of initiatives that were trying to address the problems that were happening both in rural and remote areas, but also here in the metropolitan area, and a desire to do better. And so really we wanted to make sure that we could actually have an impact on the burden of disease, not just have activity. So that's really an important part of this. And really, I think one of the things that perhaps may be something that going forward we need to focus on is really looking at the impact that this is having on the community and how we can intervene to improve that and reduce that impact, because I think that's critical. And certainly in the current climate, it's important that we can demonstrate the benefit of any initiatives that we're trying to do. And really what we wanted to do was to try and provide a framework that people actually used. So there had been a lot of work that had been going on with the strategy and a series of recommendations and models of care that had been developed, but really sat on a shelf or in a computer, and nobody really was, I guess, using them to guide what they're doing. And that's really the purpose of the strategy. And as a researcher, I'm always very keen to make sure that we use evidence to guide what we do, and whatever we do has to be sustainable. And you know, I really think that one of the tragedies in a lot of fantastic initiatives in improving Aboriginal and Torres Strait Islander health has been the short-term nature of lots of programs that sound like a good idea, but then it doesn't get continued. And so sustainability is a key part of that. And I guess from the outset, we were very keen to really try and make sure that we included everyone who was the key stakeholders who are working in this space, particularly service providers, but also policymakers and the community who we're trying to address the problems for, and improve that coordination across those organisations that are all working very hard. And I'll sort of describe where we're at, but that just to sort of set the scene. And so these were the priority areas that after, in fact, several years of consultation and discussion, we arrived at in the original strategy that was launched in 2017. And you can see here the aims for each of those strategies in terms of trying to enhance our ability to prevent ear disease and improve hearing in the first place, by understanding what risk factors are modifiable and what can we do in the community, and importantly actually communicate that to families so that they can take that knowledge and then do the best for their children. So I think that is something that I feel as though has been something that has been taken up, and there was obviously lots of things happening already in this space. I think we wanted to acknowledge that one of the issues with chronic ear disease in wherever it occurs, but particularly in Aboriginal children, was the early onset, and that whether in non-Aboriginal children as well, early onset of ear disease is an important predictor of having recurrent and chronic disease. And not only that, actually impact on hearing in those first few years of life actually has a significant impact on your language development, your auditory processing, and ultimately impacting on your readiness to start education when you enter school. And so I think it was very important that we were able to acknowledge that this disease may also not actually be evident in terms of making children acutely unwell. So we needed to be able to identify it early in life, which actually meant in infancy. And that hadn't, up until this strategy, hadn't really been done anywhere outside of a research context, even though people were aware of this very early onset. And as Frida described, the problem was that by the time disease became established, and particularly when you had chronic suppurative otitis media and runny ears, it is actually incredibly hard to treat and generally is associated with a persistent hearing loss. So the idea was to try and shift the focus from trying to look at what's happening in schools and what children needed to help them during school, which clearly remains very important, but actually how can we prevent us getting to that severe end-stage disease. And so I think actually that this is something that has been picked up both in the Child and Adolescent Health Service and WA Country Health Service to have early identification of ear disease through doing surveillance in the first 6 months of life and several times in that first year of life to understand which children are already developing disease. And that will enable us to focus on the subsequent management of that. So I think that's, from my perspective, I think, and the discussions that we've had is something that has been able to be implemented with, it's still work in progress, clearly, but actually that's been important. I think the subsequent comprehensive management and routine and regular follow-up will always be challenging, and we need to make sure that that is something that is valued by our families. And so I think that is something that we will need to continue to work on, and also understand the impact of that early screening and management. Strengthening the consistency in ear disease treatment, referral pathways, and provision of timely and accessible high-quality healthcare is certainly an aspirational goal, but I don't think that it's impossible. And so I think that's a really important aspect of just saying, well, this is a really wicked problem and we're doing our best, but we can't do that. But I think accepting very long timeframes for children to sit on a waiting list before they can access specialist services is just not something we can accept. And we have some great examples that have been developed of how we can accelerate that process so that children who need it very early in life are able to access it. And that's both within the government sector but also in the private sector through primary healthcare. And we need to think about how can we enhance that across the state so wherever you are able to access that high quality care. But it's not easy, and I think it is something that you just have to keep at and keep going and look at what the opportunities are. I think we have done some great work in workforce development, and we'll hear a bit more about that today to enable that capacity to deliver this, and I think that's something that we continue to be working at. I think embedding regular evaluation is not something perhaps that has been as easy to do, and certainly applying a research focus from a qualitative point of view, so really getting that family perspective, but also being able to document outcomes has been difficult, and that is something that we're still working with the Department of Health around. The fact we have so many people in the room here today representing a very diverse group of organisations, I think, is part of this coordination and partnerships, and I'd really have to take this time to thank Rural Health West for really continuing to support us by having these annual forums. This one is a bit earlier than we had last year, so I do understand that there are some health service providers who've booked trips to country areas to deliver services and aren't able to attend today. But I think next year we will be having it at the same time. This is a permanent shift, I'm told. Laura's nodding. So we will be able to make sure that this is in everyone's diary, and hopefully we will continue to, and sometimes it's actually the conversations you have during the coffee break that's just as important as having something written down on a bit of paper as a recommendation. And this sort of having a statewide ear disease information repository, the comprehensive evidence to guide what we do, is something that I don't think we have done yet. But I think for an area of health that really had not seen any major changes for over 15 to 20 years, this is a pretty good achievement in over the last 5 years that the strategy has been going. So we're not there yet, but I think we are progressing. But I think the feedback was, well, what should we do about this? Now, one of the other aspects that I just want to remind everyone, that the Auditor General, when he heard about the year strategy, said, so what is happening in the health service? And of course, this is most applicable for government organisations, because the government has to answer to any report of the Auditor General. But these were their 3 recommendations, and you can see here that of the 3, the ones that required WACS and CARS to work together to implement co-design for services that were outlined in the ear health strategy have been achieved, and that early surveillance and health checks has been able to be implemented as policy. So I think that is something that will be well accepted when the Auditor General's report is tabled in Parliament. But I think we still need to have much better public reporting and data that actually reflects what's going on, and understanding that the Department of Health, who are responsible for putting together and providing health data, need to look at this. I think the other aspect that is holding us back is our ability to share data between different organisations, including those outside health. And I think that's something that we really need to work better. And I think sometimes concerns around privacy and confidentiality end up actually making people worse off than actually enhancing it. And I think provided we are gaining information and storing it with consent of people to improve the services that we're providing them, and in my experience that's never been an issue with families if you can explain it, is something that people sometimes use as an excuse for why you can't do things that we're not currently doing. But I don't wish to accept that, and we will continue to push that. And clearly there's lots of stakeholders, and this was out of the Auditor General's report, at very different stages of this process. And so it's important that we engage with everyone in this context, and I think we've done quite a good job at doing that. But there's still work to do, and particularly some of the non-health government sectors that we need to work with, we can do a little bit better in that space. But I think we will be hearing from environmental health today and about how we can work together. So I think that's a good example of how cross-sectoral opportunities exist, although within health. But I think perhaps having more focus on the education department and other community support services is something we need to think about. So this is part of what everyone thinks about when they're thinking about dealing with Aboriginal children and families. So following the implementation of the strategy, we tried to put an operational set of recommendations to cover each strategy, and this is just an example of one of them where we're breaking it down. And I'm not going to go through all 26 and give you a marker on all of those, but just to understand that there is a high level, we have thought significantly about what we need to do. But this will be a changing space. Operational plans that underline strategies need to be adapted, and we also need to consider that these need to be think about whereabouts you're working and in what sector you're working, and so therefore how does that apply to you. But hopefully the strategy will give a framework for organisations and individuals to think about when they're working in the ear health space. And I guess one of the things that perhaps we can have in questions after I finish, what else do we think we need? I think reflecting on where we've been is a really good way of doing that. So at the forum last year, we had a think tank workshop that a number of you facilitated and contributed to. And I think one of the nice things was actually getting the Tuna Blues summary in a pictorial form, because I think that makes it much easier for us to get the messages across. And I think that's something, to be honest, in a health system, we need to think about how do we provide information, particularly to community, in a way that is much more easily digestible. I think we can have very complex documents that really, because of their nature, never really get read. And that's, you might have a very large policy document, but most people only read the executive summary. I think if all our documents had a visual summary like this, we'd probably not forget things that are actually embedded in those reports. And I think certainly we were able to celebrate some of those achievements of things that had been done, upskilling community and school health nurses in how to screen for ear and hearing problems, reducing waiting lists by using things like telehealth, even in an urban setting, continuing to build awareness, the growing and upskilling an Aboriginal workforce, which is absolutely critical in all aspects of health, including this one, and really, the Aboriginal controlled health organisations promoting the primary prevention strategies and some of the innovative ways that they've used using digital technology and videos with the local community was a fantastic example for that. And obviously having these partnerships. And clearly there were a number of important enablers that people recognised. Providing a culturally safe environment is critical, and being flexible to the needs of the community. Consistent and reliable funding, I guess, is something that enables us to continue to do and makes it sustainable. It's really important that the continuing advocacy for that. The coordination of ear health care is critical, and we'll hear about a case study of this after this talk. And obviously having national input from NACCHO was critical, and listening to what the families and community are telling us is absolutely critical. So, but there are still some problems, that some of which may continue to be a potential barrier that we just have to get over, such as high staff over, particularly in some rural settings, the issues around confidentiality and privacy, needing to provide treatment, not forgetting the other aspects that go with hearing and hearing problems, such as speech, occupational therapy, other health problems that these children might also suffer. We can't just think about ears, it's got to be the whole child and the whole family. And how do you access good services out of hours when you need to? And that's really important, so that awareness of and obviously one of the biggest issues is there's a lot of things we want to do to try and close the gap for health for Aboriginal families. How do we make this an important part of them, and why should people focus on this as well as all the other things that they have to do? And that's really critical, and that's not an easy one, I'd have to say. Some of the future strategies that were suggested, thinking about how we can sort of go to the digital age, so that data that can be collected just through the day-to-day records that we keep, and in such a way that actually it informs us of what's happening in the outcome. I talked about telehealth, that I think we understand is really important, and we've had some great examples of how that works in a metropolitan area, but also even within a region such as the Kimberley, to get the right follow-up and the families able to see the right specialist. Consistent screening, we still need to do research. Environmental health was one of the things that I think perhaps we didn't highlight enough in the original strategy, and we are all aware of the social determinants that lead to children having a variety of infectious and chronic diseases, including otitis media and hearing problems. So we need to think about this in terms of both prevention, but also as part of our management when there are issues. Having an ongoing Aboriginal leadership and voice is critical, and it really pleases me to see so many Aboriginal leaders and health practitioners in this room. And then looking at new models that we can continue to develop, and making sure that everyone feels safe when they're improving it. And obviously also access to surgery is a critical one, and how can we provide support that people get there. So these are all sort of strategies that we've thought about, and there's a number of examples of all these that people are already doing, and I'm happy for you to comment about those. Clearly, this sort of community involvement, engagement in health promotion was really important for those successful programs. We understand that importance of environmental health, and really this trying to make sure that we focus on the family and the child, and what suits them, and how do we get them to where they need to be, and how can we make sure we don't lose track of that. It's one thing for a child to be seen and said, you have a problem. It's a disaster if that doesn't then get followed up, because we sort of actually are disempowering families from seeking healthcare again. And Frida talked about that with children with chronic otitis media, why they stopped turning up. Clearly, I think we need to make sure we get great stakeholder collaboration at the regional and the state level, and there's certainly a lot we can do in the data efficiency and innovation space. And I think health is getting better at this more broadly as a policy, and trying to utilise the data that we currently have, and then clearly developing and measuring our key performance indicators and outcomes was critical. But we can't forget these workforce needs, and that's something that will be ongoing and is something that we really need to focus on, and particularly building our workforce capacity. So these were some of the suggestions that came through. And so we sort of had a couple of workshops earlier this year, and thank you to everyone who attended. So 19 organisations, reflecting how many people are working in this space. Thank you. And the attendees who came, who sort of really provide pretty direct feedback on what was working and what wasn't working, and how we maybe need to shift some of the attention. But I think the overriding thing that I got out of it was actually acknowledging that actually having a strategy was useful, that the recommendations did actually provide a pretty broad framework that people could work with, and helped guide some of the policy that was developed in the processes that they were using. And that we had made significant progress, but not in all the areas. And it was clear that one of the issues was coming up. We weren't really telling people how we were going as well as we might. We said, this is what we're trying to do. It's great. And these forums have been fantastic to hear about those examples where this has really worked well. But we need to be doing this on a continuous basis so that we really measure those outcomes. We also had feedback that about environmental health and how this might change in the model of care, and need to be more involved in that. Really that involvement and engagement of community in the strategy implementation, and not forgetting the pivotal role in of primary healthcare in this space. But I think one of the ones was really making sure we knew who is responsible for different aspects of it, and how can we use this monitoring and evaluation framework so that we knew that what was working and importantly what's not working as well as we would like, and making it more accessible, so not having such complex recommendations, but trying to really break them down as part of that process so people find they're more useful. And ideally these progress trackers would also work at a regional or local level. And this is just an example with the recommendations from the prevention and standardised surveillance about what is working, what's known, things like newborn hearing screening. 99.1% of children will have a newborn screening. Part of the problem though is if you fail and you're an Aboriginal baby, you're less likely to get followed up if you're a non-Aboriginal baby. So there's something work to be done there. So I think we need to understand what's working. We have universal school entry hearing health assessments, but how do we use that data to guide our progress is something we need to think about, and so on. So I think an understanding, broader items like a national MBS item that helps GPs get more engaged in ear health screening for tympanometry and so on. So we need to think about that. And certainly the opportunistic screening that's happening in young children. Well, what about older children, and how does that work when they're being seen as part of their other interactions with health services? So there are some pieces of work, and as I said, that interdepartmental and interagency engagement is something that perhaps we could do better in. So I think we wanted to have a much more sophisticated approach to the data that we collect and be a bit smarter about it. I think we've had talks about how we might use AI in the future. The importance of workforce development, particularly Aboriginal health practitioner staff, and acknowledging the fantastic work they do and the career path that can be developed. We need to work better with the Department of Health centrally as a systems manager around what tools we need to do that. And although there is some work in this space, I think we need to really accelerate this and really make sure that the Health Executive Committee and the Director General are well aware of what the issues are and what we're doing. And part of that is really making sure that we align with other broader health directives that are national, such as Closing the Gap, or within health department, and with such as the Sustainable Health Review or the new 1,000 Days Initiative, First 1,000 Days Initiative, where this is why we need to do what we're doing. So this is important in how we link with national programs to maximise our resources and how we use them. Integrating the strategy with other government sectors and health providers. So think a bit more about that stakeholder engagement and communication that we have to do this, and clearly just making sure that community engagement is embedded throughout the strategy and what we do. And I think everyone is well aware of this, but perhaps sometimes we just need to state it a bit more easily. So I think we are doing that, but perhaps we can do better, and perhaps actually having a specific community reference group for the strategy would actually enhance our ability to make sure that we hear that voice all the time. I've had discussions with our new Director General of Health, Shirley Bowen, who has a public health background, so is happy to look at the aspects of ear health and how we might reprioritise resources for it. So we're organising a meeting with her to talk about this. Continue to develop these collaborations and partnerships and that evaluation framework that's relevant to service providers as well as families and community. And this coordination piece, I think, is still important. And there may be some resourcing issues, but we need to pay attention to those. And finally, continue to look at new strategies that we can develop. You know, we have a new immunisation for prevention of RSV that's an important cause of otitis media, making sure that gets high coverage in Aboriginal families. And other resources that we need for better and more effective communication in the short, medium and the long term. So this is just a summary of where I think we've come from and where we need to go. And I'm happy to take any questions or comments now or during the breaks, and just to acknowledge the fantastic work of all the steering working group members over the last few years and those who are continuing to work with us now. And to you, the other stakeholders in the strategy that have really made a contribution. And I'm happy to take any questions or comments people would like to make. I think we've got about 5 minutes for comments or questions. Hi. And if you could maybe just say who you are as well and where you're from.
Thank you. My name's Rochelle. I'm the Medical Director at Derbil Yerrigan Health Service. Thanks very much. And we were also present at the Ear Health Strategy workshop, which was great. I think one of the things you said around data, and I don't know how can we get a bit more transparency around the waiting lists, and we still have such long waiting lists just to be able to see the specialist, and then again waiting for surgery. And it feels as though a lot of the archo sector is kind of bypassing the system in order to get kids seen, but we just don't seem to have that transparency on how many kids are on the waiting list, why is it so long, etc. And is there any way we can kind of go through it, because a lot of the kids might have been done elsewhere or seen, that kind of stuff. How do we get that information? Yeah.
Although there is some public documentation of waiting lists that's mostly for surgery rather than waiting lists for outpatients, which is what you're talking about. So there's two big wait list issues there. Personally, I think this is something that is available on dashboards within health services, and I see no reason why we shouldn't do that. My discussion, and Chris Brennan-Jones might want to comment on this, on some of the work he's doing to look at this, but is that it's about how we prioritise it. So if we say we're referring a child who's under 2 with recurrent ear disease, that should be a high priority. That's I know there are other high priorities within the ear health space, but I think we know these are the children who are going to run into problems and continue to run into problems, and waiting 2 or 3 years is not good enough, because they'll be starting school then. So I think we need to do better, and I think it's probably about a model of care and what that might look like. Chris, do you want to speak to that from the point of view of the telehealth clinic?
Yeah, sure. So, hi everyone. I'm Chris Brennan-Jones from Telethon Kids and PCH as well. So, we have run a project basically trying to do an urban telehealth program at PCH, and what we have found there is that about 40% of the referrals that we usually see them within 28 days. About 40% of the referrals to the hospital we see have normal hearing and good ears, which is obviously, it creates sort of a bottleneck point for the hospital, because we're getting a lot of referrals, and from the referral itself it's hard to triage the severity, and so you have a lot of severe cases as well as a lot of mild cases coming all into the same pot. The other trouble we've had trying to do this project is we've gone through about 1,600 referrals, and we contact them all, but people don't want to pick up the phone these days as much as well. So I think we've managed to see about 350 kids through this process, and obviously that's basically eliminated their wait list for the outpatients process. But I think we need to find better ways to decentralise as well than having this central referral service too, I think. I'm not sure. I don't have all the answers, but it's it does create a bit of a bottleneck for the specialist care.
Yeah. And oh, sorry, Rochelle? Oh, sorry, can you speak into the microphone? Just
question.
How many kids are actually on the waiting list, and whether or not there's capacity for someone to go through and see if they've been seen elsewhere, like what we do at what Stephanie, our ear health coordinator, does at Derval and other ear health coordinators.
Yeah, so the question was how many people are on the waiting list, and is there a way to go through? I don't know the exact number of children on the waiting list. I mean, I know it's in the thousands, but I don't know the exact number, but it's a lot. And there is, so we are going through that process of triaging the referrals, but that's been as a research project. So I suppose now we're reaching the end of that, and we need to make that into the standard practice and also expand it so that we can actually get through all the referrals, because we're still just scratching the surface, really. Yeah.
Another question? Yeah, Clary.
Peter, just from my experience with, I've had a look at the wait list. There's over 2,000 names on the PCH wait list for surgery, but then there's a wait list for outpatient services.
Yep.
One of the challenges is actually identifying which children are Aboriginal and which ones are not Aboriginal, because the data's not necessarily that accurate, and that's a challenge, obviously, in the system. We've recently had discussions with Fiona Stanley. They say they've only got like 30-odd kids, Aboriginal kids, on their wait list for surgery, which I can't believe. So, the issues around the accuracy of that data as well. Yeah. And some challenges there.
Yeah, so adequacy of documentation is important, but I think if we're getting a referral. Yes, Mel.
Hi everyone, Mel Robinson, Director of Aboriginal Health at CARS. Just want to reassure Rochelle that from the inside we are really keen to share data. I think the problem we're having is the quality of it, but we're definitely going to start looking at that. So the Aboriginal Health Dashboard within WA Health is going live soon, but ear health isn't in there. There's going to be a separate dashboard, which I have issues with, but anyway. But we do want to be transparent, and there's going to be an Aboriginal data governance process. There's a committee that's going to look at requests, and you can absolutely start putting in requests once that's all. So hopefully by next year we'll have some good news for you. I think the other thing, we're trying to clean up our house internally as well, and we've been doing quite a bit of work with our community health screening services and our hospital services, because we found a wait list that had 160 children in it that nobody had eyes on, and we've cleaned that up. So we're trying to improve our own house before we look outside, because we've got to hold ourselves to account as a health service as well, and it's not good enough that there's thousands of kids. But also I think there's a piece in the referral around educating, because putting a 1 sentence in a referral isn't going to get us to be able to triage, and then it's a lot of work. So the referral process needs a clean up as well, making sure that, you know, whoever's referring actually puts the information in, and that sits with us as well. You know, what information do we need? What's important? So there's so many bits to this, but I feel like we are making progress, and I just want to reassure Rochelle and everyone else, you know, while I'm still around and there's others who are on the same page, we'll keep pushing the system and we'll hold ourselves to account as well. Just wanted to say that.
Thanks, Mel. And I'd just like to acknowledge the great work that Mel has been doing in this space, really making sure that it's prioritised, but it is a challenge. And I think the thing about communication, sometimes that's about how long ago it was you got referred, because if you communicate with families soon after referral for any condition, like not just ear health, they're much more likely to answer and engage. They've probably decided that it's either not a problem or that there's nothing happening, which is even worse, because it's not often the case, particularly with Aboriginal kids. Yeah.
Good morning, my name's Philomena. I come from Derby Aboriginal Medical Centre up in the Kimberleys. When I've been listening to everything, there was a few things that were running around in my mind. Number one is, as in for communicating with our mob up there, mobile phones get handed around. They get lost. And one of the things really good that I really appreciate is a lot of the services make contact with our medical centre and they say, we're looking for so-and-so. And our drivers and our staff are magnificent. They'll go out of their way to try to find that family. There is, for us as well, there's a breakdown. Our mob don't want to come out of the Kimberleys into this great big city. Yeah. It's really scary. You mob got a lot of cars here and a lot of people, you know. Yeah. And there's a new system when you're staying down this way. So it's also really difficult to find somebody that'll escort that child down here. Yeah. There are some around that well. I used to work at a Aboriginal hostel, and I watched the DARS run around for a long time trying to find an escort for a child to come down for an ear operation. And it was only because of that fear. They got to get on the plane, they got to go from Derby down to Broome to catch the plane, then they've got to go on that great big jet all the way to here, then they got to find their way from the airport to where they're staying. I must admit, nowadays it has changed a little bit, but there's that big fear of coming down into this big city, and it's the moving of mobile phones that make it harder to make contact with our mob up that way.
Yeah.
Thank you. I just wanted to share that little bit with you, Zay.
No, look, and I think this is really important to recognise that you need different solutions in different settings, and yeah, I mean, and you know, I know part of the problem is from my hospital. If you ring somebody from the hospital, it comes up as no caller. So people think they're going to get scammed if they answer the phone, so they don't answer the phone. So I do think more broadly we need to understand what communication strategies work, and make sure that we can coordinate those services. Are there any other questions? Yes, Lorraine?
I was just going to add on to what our lovely lady over there was just talking about, and that transition and the referral process. I think, you know, it should start between the two services, the communication lines, and about, you know, arranging that prior and post to ensure that they have got that, you know, the journey is smooth, pretty much.
No, I think that's right. And wherever possible, deliver services in on country.